My name is Marty Cosgrove, if you haven't figured that out by now, Vice President. It's truly an honor for me to introduce Ann-Louise Silver. Ann, first of all, if you don't know Ann, you're really missing something quite wonderful. And you owe it to yourself sometime between now and the end of the day to pull her aside and chat to her and get to know her, because it's really, it's a good thing. Let's just say that. Ann was our founding president. She was our president for the first 10 years. I met her actually in 1994 at Chestnut Lodge when we had the international meeting. It was in passing, and I was pretty alone that weekend, so none of those connections stuck. Thank God they have now. Rather than read everything that you can read for yourself, let me just tell you that Ann is a master at what she does, and she does all sorts of things. One of the things she does is she gets invited to speak about all sorts of things all over the place. Ann gets invited all over the world to talk about patients, about this work. I think she's one of the most knowledgeable historians of this work and the traditions, really. One of the things you may not know about Ann is she's probably, at this point, maybe one of our most direct linkages to Frida Fromm-Reichmann. Her analyst was Harold Searles, who was analyzed by Frida. No? I always get these details of her life wrong. Maybe she'll clarify. Anyway, a few words that come to mind when I think of Ann are integrity, passion, love, and determination. And I've seen that in her work in this organization. I've seen that firsthand with her family. I've seen it on their wonderful farm in upstate New York. And I've seen it in my own relationship with Ann. So I could talk for hours, and that's not why we're here. So anyway, Ann.
Well, Marty, thanks for that very generous, warm introduction. The connection, Harold Searles was on the medical staff at Chestnut Lodge during the time that Frida Fromm-Reichmann was the director of psychotherapy. He was in a seminar on intuition and the treatment process of schizophrenia, along with Don Burnham, Marv Adland, Alberta Shalita, and run by Fromm-Reichmann, and there was a court stenographer there, so we've got the complete minutes of that meeting. And then after Fromm-Reichmann's death, her cottage at the lodge became office space for different doctors on the staff, and he felt that she was still haunting the place when he had the office that was next to the bathroom where she was found dead. She had died of congestive failure, and maybe complicated by a flu. So they were colleagues. His analyst was Ernest Hadley, who was one of the founders of the Washington School of Psychiatry and a very close supporter of, and with various complications with Harry Stack Sullivan. And he was prominent in the politics of that era in the American Psychoanalytic. And it was Ernest Hadley who was analyzing Dexter Bullard when Frida Fromm-Reichmann had come to this country in 1935, and he had arranged for her to come and work as summer help, and she stayed there working for the rest of her life and putting the place on the world map. So I'm going to talk today about this possible diagnosis of early psychosis syndrome, which has created quite a furor. If people have trouble hearing me at any point, you know, wave. Maybe I'll have drifted away from the mic, or I'm too close to the mic, whatever. So I want to thank everyone here, especially the organizers of this meeting and the ISPS-US Executive Committee for honoring me and my work over the past few decades. You've all been sustaining me over the years of having lost my professional home at Chestnut Lodge, and as we work to grow our professional home here. Any honor to me goes also to my husband, Stu. He was the key contributor to our getting our 501c3, and he's bailed me out of innumerable tech panics. Today I saw the gift I want for our upcoming this spring 50th anniversary, a blue 1960s Studebaker convertible. As you know, I've anguished over the pummeling psychodynamic work with patients suffering from psychosis has endured, and I've reveled in the pushback that ISPS has produced. But we must move from reactive to proactive, not just crying no to some new pharmaceutically driven initiative, but becoming proactive, producing our own initiatives. At our recent leadership retreat, Jessica Aranella and Laurie Kalman McCartney, Yulia Landa, and Brian Kohler, with the rest of us all joining in, those with Mac computers who were able to get on the internet, I wasn't. They produced a preliminary outline for treatment guideline and began developing a list of relevant websites. Next will come our first grant application. So we're entering our next phase of development. My current concern is the American Psychiatric Association's upcoming DSM-5 with its possible new addition, a diagnosis of early psychosis syndrome. My lodge tenure spanned the final 6 years of its medications avoidant phase in the late 70s and early 80s, then its medications accepting phase, its phase of plummeting finances after it was sold to a local clinic in 1997. We all saw the negative effects of a seemingly scientific study. Tom McGlashan's Chestnut Lodge follow-up study reported that, looking in the 1980s at how lodge patients who'd been there between 1950 and 1975 were doing, he and his team, that 1/3 were improved, 1/3 of those were fully recovered, and 1/3 were about the same, and 1/3 had deteriorated. Even though essentially all the patients who came to the lodge had started out in the bottom third of the lower third. He announced, even so, that Frieda from Reichman's and Dexter Sr.'s grand experiment had failed. Nobody noticed that the study design included all the patients admitted, even if they'd only stayed a day or a week or a month or even 3 months, rather than experiencing the analytic program in its full relational intensity. And I don't have the numbers at this point, but there were quite a few who would come and then panic, or the parents would panic, or somebody would say something that offended someone and they'd pull the patient out. So there were quite a few people who were in there diluting the positive effects of the lodge treatment. Additionally, the design set the bar quite high for recovery. Full employment in an ongoing intimate sexual relationship, for example. In the no-meds phase, I had the deep satisfaction of seeing some of my patients recover, choose careers, marry, and raise a family. I experienced the really abrupt transition when later patients were placed on meds. The intense and delusional material we struggled with disappeared almost overnight, replaced by more polite and coherent conversation with no mention of what had preoccupied them in the weeks before. Our intensely ambivalent attachment was gone. Our sense of a tentative adoption vanished. These patients often rather quickly could attain outpatient status, but their career desires had gone, their needs and fears for friendships diminished, and they basically stalled. Frequently, they withdrew into their rooms smoking marijuana. Staff discussions often focused on the very low rate of employment or scholarship among our outpatients. This had not been the case in the earlier non-meds era. Kshitiz Kapoor is correct in saying that the antipsychotic meds work by blocking psychotic salience. Salience is that sense of emotional commitment or excitement that comes from that aha moment of recognizing something as really important or true. Patients still hear the same voices, but they don't care about what they're saying as much. Their delusions no longer captivate them. He identified dopamine as the key agent acting on the D2 receptors and localized that function in the mesolimbic system. He showed that the medication with the atypical antipsychotics, a person suffering psychosis will no longer feel so committed to listening to his or her voices, feeling that their seeming directives are leading him on the true path. These so-called antipsychotics are dopamine blockers. The big problem is that the meds can't tell the difference between psychotic and non-psychotic salience. They simply block the aha centers of the limbic system. Once on meds, nothing and nobody excites that person like they had. Nothing stands out as more stimulating, worthy of note, or important. Patients complain that they feel like zombies. That's because the meds work by muting salience, the reaction of pleasure at solving a problem, understanding a concept, reacting to something with aesthetic resonance. Serendipity, making connections seemingly by luck, becomes nearly impossible. Patients complain that the meds make them feel like zombies because that's the way the meds work. It's not a side effect, it's the dominant effect. We saw that at Chestnut Lodge in the countertransference. Once the meds came in, the Wednesday conferences, which were 2-hour events focusing on the work with just one patient, became more rote. The discussions no longer dealt with the participants' reactions to the presentation of the analytic work, but they derailed into debates about the meds. Attendance dropped off as we, in our unfocused way, lost our own salience. Our center didn't hold. Joyce McDougall sat in on one such conference and whispered to me, "Where's the analysis?" I felt ashamed of my hospital. I've kept my nostalgia for that earlier era, during which time, when treatment worked out, a deep trust and loyalty developed. Big Pharma's latest push, headed in the United States by my almost neighbor Will Carpenter, is to define an early psychosis syndrome or psychosis risk syndrome. His research group is at the Maryland Research Center on the grounds of Spring Grove Hospital Center, close to where we live. I'm concerned that if this new diagnostic option finds its way into the Diagnostic and Statistical Manual 5th edition, it'll become immediately popular, accompanied by an immediate prescription of a salience-blocking med. I'm not alone in this concern. Alan Francis, who was the editor-in-chief of the DSM-4, most regrets the introduction of an entity of childhood bipolar disorder and dreads the 40-fold increase that we saw in this diagnosis. He has been forcefully and repeatedly sounding the alarm about the possible early psychosis syndrome, which would be a delusion or hallucination or disorganized speech having occurred, but reality testing must be retained, however, and the symptom must not interfere substantially with thinking, social relations, or other behavior. Reading this, I recalled an incident when I was maybe 14. I accidentally knocked an antique porcelain figurine off its sconce on the wall over my desk. It fell and her hand broke off. I loved that graceful Mozartian young woman. I saw I could reattach her hand and would hardly see the fracture line, and then I began screaming and crying. And when my parents came into my room, I screamed repeatedly, "It's not broken, it's not broken." And they kept answering, "It is broken, it is broken." And this went back and forth. And finally, my father said, "We can fix it." And I said, "That's what I was trying to say." I was so upset that I couldn't convey my thoughts. Now, if they'd just heard a warning about early psychosis syndrome, they might have taken me to a clinic for an evaluation, and who knows how it might have turned out. Early psychosis syndrome promises to be a popular diagnosis given the current US hysteria to identify and medicate the crazies before they shoot into another crowd. People want to identify these bad apples and medicate them so they won't even think of purchasing a semi-automatic weapon. Medicating teens so the world will be a safer place, magic bullets of meds replacing a potential spray of actual bullets. Somehow this seems more acceptable than enacting laws restricting the sale of semi-automatic weapons or restricting the availability of weapons in general. The statistics regarding the minuscule number of mentally ill who resort to violence and the enormous violence done by criminals or by children playing with weapons purchased for the family's protection, or the now acknowledged factor of the SSRIs in triggering bizarre violent outbursts in teens, these facts seem irrelevant. And as you may know, the NRA is making progress with state laws making it illegal for pediatricians to even ask parents of young children whether they keep firearms in the house. Fortunately for us, Hanneke Wigman is completing her PhD dissertation, and she is receiving international notice for her findings. She has found that half of Dutch teenagers regularly have a mild psychotic experience. Mild psychotic experiences include hallucinations, delusions, paranoia, megalomania, and paranormal convictions. Using self-reports, Hanneke Wigman compared the prevalence of such psychotic experiences in teens to adult women ages 18 to 45, and found that only 2% of adult women self-reported these phenomena. She found megalomania was reported more often in boys than in girls. Hallucinations, delusions, paranoia, paranormal convictions occurred more among girls. Thus, adolescence is a period in which feelings of uncertainty play a role. Young people become more aware of themselves and are often sensitive to their changing social environment. That makes them more susceptible to paranoid thoughts and observations, for example. For most young people, mild psychotic experiences are transient in nature. If young people experience something like that, then they do not need to panic, according to the researcher, but they should stay away from cannabis. Meanwhile, blocking salience impedes meaningful psychotherapy. Sometimes something a troubled teen needs much more. I fear that the current pharmacologic advertising, which proclaims without scientific support that mental distress is the product of a brain disorder, will continue to be considered a fact worldwide. Regardless of the DSM outcome, ISPS will need to insist on a psychological component in the new push to identify adolescents and young adults in danger of developing psychosis. I picture the pharmaceutical industry producing questionnaires, as they did in the Depression screening days, but now distributing the early psychosis syndrome questionnaires in high schools and colleges. Those who indicate high levels of anxiety along with paranoid notions or hallucinations would then be referred to a psychiatrist who would recommend meds. Anyone who comes to the attention of the school's mental health staff deserves to work with someone psychologically before being urged to go on our current salience-muting crop of so-called antipsychotics. Fortunately, this idea is getting real support. We need to revisit the message of Adolf Meyer, who led American psychiatry in the mid-20th century and who was the leader in the creating of the first and second DSM. I wonder if, a show of hands, how many people have heard of Adolf Meyer? That's cool. I don't always get that. He stressed the importance of developing a life chart for each patient, getting clear with that patient about the person's history. And that is not just identifying traumatic events, but when they occurred and what preceded what and how the first thing played into the second thing. Understanding one's past and one's family's past, its victories and its traumas, is the best guide to evolving one's own future, as Françoise Devon and Jean-Max Gaultier have developed in their book. Andrew Morrison has reported on his research. He and his group identified a large group of young people who met the criteria for early psychosis syndrome, and they followed them in monthly appointments where they simply filled the people in the study just filled out a questionnaire and then left. The group found that only 8% of those kids actually went on to manifest a psychotic illness. When he was asked why so few actually became psychotic, he said, "I guess because when they came into the clinic, we were nice to them." In a paper published just a month ago, Toni Morrison, with colleagues who included Doug Turkington, reported on a study of a group of 20 participants with schizophrenia spectrum disorders who received cognitive therapy but no meds. The PANSS scores, that is the positive and negative symptom scores, showed that at 9 months, 35% of them, and at 15 months, 50% of the participants achieved at least a 50% reduction in their PANSS scores. No patient deteriorated significantly. This provides preliminary evidence that cognitive therapy is an acceptable and effective treatment for people with psychosis who choose not to take antipsychotic meds. So we're pulling out of the swamps and getting onto firmer ground here. For the past 3 decades, the pharmaceutical industry has bought the mental health professions and our clients in the United States and increasingly around the world. Treatment now is synonymous with medication, and advertisements imply that these meds somehow protect the individual's brain from deterioration, and that there is actual urgency to getting sufferers onto meds. Increasing numbers in the US have instituted laws giving judges the power to require people to take meds on an outpatient basis, usually by injection. Grace Jackson, MD, as developed in her 2009 book, Drug-Induced Dementia, has documented in her extraordinarily diligent search of the literature that these meds gradually do cause neuronal death in brain cells in a process called apoptosis. Robert Whitaker, through his books Mad in America and Anatomy of an Epidemic, has documented the enormous rise in the number of people in the US receiving Social Security disability insurance payments. Are we treating sick brains, or are we sickening brains? Nancy Andreasen, who's a very prominent researcher receiving very many awards, and the editor-in-chief of the American Psychiatric Green Journal, the American Journal of Psychiatry, holding that post for 13 years. She, with her colleagues, reported last month that while alcohol and illicit drug misuse showed no significant effect on brain volume, there was a clear correlation with chronic use of antipsychotic meds, with the higher dosage correlating with the greater effect. Illness severity had relatively modest correlations with tissue volume reduction, that is, brain shrinkage. They concluded, quote, "Viewed together with data from animal studies, our study suggests that antipsychotics have a subtle but measurable influence on brain tissue loss over time, suggesting the importance of careful risk-benefit review of the dosage and duration of treatment as well as their off-label use." I.e., we're seeing ads on TV that if you have chronic pain, it would be good to be taking these things, it'll help. Or if you have trouble sleeping, it'll be good. Or if you're anxious, it'll be good, and so on. If you want a smaller brain, that's fine, go for it. Their paper includes a careful review of meta-analyses calling into question the efficacy of the atypical antipsychotics. Data coming in from around the US is reported by the National Association of State Mental Health Program Directors show that patients diagnosed with schizophrenia are living 25 fewer years than their healthy age mate. A few are dying by suicide, homicide, or accident, but the majority dies from cardiovascular and metabolic illness, primarily diabetes. Before the introduction of the atypicals, patients with schizophrenia lived only 15 fewer years than the healthy. The meds quiet the limbic system, but also wreak havoc on endocrine and cardiovascular systems. The SSRIs make their own contributions of problems, and the complex cocktails most of these patients are prescribed have unknown neurologic consequences as the brain tries to compensate for the effects of these drugs. Current mental health trainees rarely are taught the basic principles of psychodynamic work. They dread the patient's potential to harm themselves or others, and they dread the lawyers closing in on the therapist, with the imagined courtroom becoming the scene of a huge public oral exam with the prosecutor railing, and you call yourself an expert, doctor? My primary hobby is vegetable gardening. I'm part of a rapidly growing number of enthusiasts who raise heirloom varieties as purchasable just a few feet away from here. These heirlooms are the progeny of seeds brought from Europe or Asia or South America by our forebears. These plants have not been hybridized or genetically modified for industrial farming. Plants whose produce will ship well and keep well in storage. The old-fashioned plants produce more fragile but far more tasty vegetables. Their variety is exciting. Purple, white, or red carrots with rich flavor, tomatoes in seemingly infinite variety, and near addictive flavor. You save the seeds from one of the fruits and you're set for next year. Just as this old-fashioned method of gardening is taking hold, it seems that the old-fashioned approach to human dilemmas is finding its enthusiasts, some of whom have found their way to ISPS. We probably all believe firmly that trauma contributes very significantly to the probability of later breakdown. History matters, as documented in the research of John Reed and others. We were not startled by Richard Bental's keynote address, finding that early trauma correlates strongly with later paranoia. Excuse me. We question the relevance of diagnosis and see its dark side. It supports stigmatization and conveys a message of hopelessness and implies a scientific medical backing, whereas the reality is closer to a consensus report of a committee whose members often have close ties to the pharmaceutical industry. We stress the importance of getting to know the suffering person and his or her family, learning their histories in detail, knowing that this is an integral part of the treatment process. We want to know about the person's strengths, accomplishments, and interests, and not just the problematic stuff. And we plan to stay with them until the patient decides we're no longer needed. A process that Marilyn Charles's case presentation very nicely illustrated. My father, a public health pediatrician with a deep interest in psychoanalysis, once told me in one of his attempts to talk me down from some frustrating argument I was having with my mother, adolescence is a time of normal psychosis. He added, older people are more brittle, more set in their ways, so it's the responsibility of the younger one to be more flexible. Here's a rather universal paradox. Adolescence is a time of brain reorganization. One's childhood capacity to hold an enormous number of informational bits in mind, the capacity to learn a new language, to retain data points on the performance of large numbers of sports players, or the county seats across the state or nation, or naming the world's rivers, all this weakens, replaced by a new and awesome capacity to philosophize, to draw conclusions from bits of observation, and then to build systems from these conclusions. The building blocks of this newfound personal perspective or philosophy, in some ways in agreement with the parents, but very often in marked opposition. But these personal philosophies are built in a sense without mortar, unstable like the building block castles of our childhoods. My dad would have loved Wigman's Dutch survey of teens. To rephrase his attempt at helpful negotiation, adolescence is a time of schizoid flowering. We all find ourselves waking up with the question, why am I me? Do I have a purpose? Some of us push the questions away with frenetic activity or experimenting with drugs and alcohol. It's as easy as finding rocks in glacial moraine as it is to find schizoid or pre-psychotic features in an adolescent. Essentially, all teens have more craziness in them than they did as children or will have as adults. Potential for disorder in this newly emerging neuronal rewiring is universal. If this new diagnosis becomes official and any psychiatrist can be reimbursed for applying it to an insurance form, we might as well add antipsychotics to every teen's morning orange juice. But we'd end up producing a flatter, less motivated, less creative population with even more obesity than now and with significantly shorter lifespans. Nancy McWilliams emphasizes the widespread use of schizoid mechanisms in the general population and its prevalence in mental health workers, especially among our philosophers. She notes, however, that when it comes to diagnosis, we've tended to stigmatize whole groups who are in apparent minority, gays, schizoids, foster children. She said, quote, "We've tended both to equate dynamics with pathology and to generalize about a whole class of people on the basis of individuals who have sought treatment for something problematic about their idiosyncratic version of their psychology," unquote. If I were to ask here at random, you in the third row on the aisle, what's the craziest thing you remember thinking or doing as a teenager? I imagine getting answers like, I don't remember, or it's none of your business. I'd do much better to ask in private. I would be illustrating the role of the group in our ability or desire to communicate. Our place in the group becomes crucially important beginning in adolescence. The don't associate with that one, she's crazy, or I don't want him in my club. This is the groupthink reified in the DSM. Pathologizing equals excommunicating. The psychiatric community has double and conflicting missions. One, to calm the anxiety of a suffering individual, and two, to provide a way of delineating the abnormalities that afflict humanity and to design generalizable methods of addressing these clusters of abnormality. Mainstream is right, outliers are weird, wrong, crazy. This is the adulthood that adolescents dread, the brittleness and resistance to the wild and wacky, what is new and transformative. The DSM has become the mechanism for creation of, in quotes, illnesses to be marketed to the world, along with the accompanying meds. Eric Waters' book, Crazy Like Us, and here another hand raising. How many have read that book? It's a very clear, compelling, nicely constructed read. The world looks to the US for its entertainment, for its power to police, for its fashion statements and its discoveries. Our DSM and other pronouncements of the APA is the major influence on the World Health Organization's publications. These set the fashion standards for how the people of the world express their varieties of anguish, as Waters documents. This happens one person at a time as people in Hong Kong learn how anorexia nervosa is supposed to be expressed. People in Zanzibar learn the correct presentation of schizophrenia, and the Japanese learn how to be properly depressed. While the patients are learning how to play their parts, the clinicians are studying the latest treatments and have learned the correct ways that the disorders present. They too have their need to belong to their group, to be loyal to its dogma, and this is a devastating combination. The World Health Organization compared the course of schizophrenic illness in 3 industrialized and 3 developing nations. In 1969, they repeated the study again in 78 because they couldn't believe the results the first time, but they got the same results. They found that the recovery rate from schizophrenia is about 30% in industrialized countries. It's about 60% in the far poorer economies. Those of us in the US were never taught about these studies. Our teachers apparently assumed the studies were somehow flawed. The researchers followed up in 1997, interviewing patients from those two studies some 15 to 25 years after the initial contact. Again, they found the same outcome differential. As Robert Whitaker states in Anatomy of an Epidemic, quote, in the developing countries, 53% of the schizophrenia patients were simply never psychotic anymore, and 73% were employed. The bottom line is clear. The countries where patients hadn't been regularly maintained on antipsychotics earlier in their illness, the majority had recovered and were doing well 15 years later. In the US, Courtney Harding has documented we have about a 30% recovery, and those are the people who have the confidence to discontinue their meds. Whitaker asks, if we really have advanced dramatically during the psychopharm era, why have the numbers of disabled mentally ill in the US skyrocketed? And why has this, quote, modern day plague now spread to the nation's children? He says, in the short span of 20 years, the number of disabled mentally ill children rose 35-fold. He interviewed a foster mother who cared for almost 100 kids, who said, quote, when I look back on the kids that stayed on the drugs and those who got off, it's the ones who are off that are the successes. The thing is, if you get off the drugs, you start building these coping mechanisms. You learn internal controls. You start building these strengths, unquote. Then, amazingly, just this past July, the two leading experts on psychosis risk, Pat McGorry, who was the chair of an ISPS international conference a few years back, and his colleague Allison Jung, publicly withdrew their support for the inclusion of the psychosis risk in the DSM-5. On August 21st, this past August, Jill Stark reported that Pat McGorry, the former Australian of the Year, aborted a controversial trial of antipsychotic drugs on children as young as 15 who are at risk for psychosis, amid complaints that the study was unethical. 13 international health experts lodged a formal complaint calling for the trial not to go ahead. And I wonder, why wasn't ISPS involved? I don't know who the international health experts are, actually. At this point, maybe some of them are ISPS leaders. The experts argued that there was little evidence that the onset of psychosis can be prevented, and it was potentially dangerous to use antipsychotics on those who merely had risk factors. McGorry insisted at the time of this interview with Jill Stark that the decision to scrap the trial was made in June. It was unrelated to the complaint, which he said he had only been alerted to just over a week ago. Associate Professor Jeff Stewart from La Trobe University said, quote, there's a major ethical issue about medicating 4 people to supposedly save the 5th. When you're not saving them anyway, you're just masking their symptoms, unquote. Recently, I received an email from the American Psychiatric that I'm among 200 researchers invited to voice an opinion through SurveyMonkey on issues regarding the diagnosis. And we've been invited to locate 10 additional people who will also respond to the questionnaire to be posted soon. I've pulled together a team. I still have some openings, so please volunteer if you're interested. I believe I'm on that list because of the earlier work of ISPS-US when we confronted Anthony Lehman and his crew who had created the PORT, the Patient Outcome Research Team Recommendations, which was widely publicized by NAMI. It had recommendation 22 that psychodynamic therapy should never be done if someone is diagnosed with schizophrenia, and family therapy that looks for the roots of the illness in family dynamics should never, in italics, be done. So we got those recommendations removed, but Lehman said in the intro to the revision that they dropped that because nobody's doing psychodynamic work with psychotic people anymore, and they don't comment on outmoded treatments, just as they don't comment on lobotomy or insulin coma treatment. Thank you, Tony. So we created a spectacular publication which forced the authors to take notice. I was then invited onto an earlier survey project responding to the APA treatment guidelines for schizophrenia, which had drawn heavily on the Port Report. The key player in this thing and our positive results was Wilfrid Ferecki and his clear and philosophic piece, which now is in the Kaplan and Sadek textbook of psychiatry. So thank you, Wilfrid. But anyhow, this kind of pushback is reactive and not proactive. We do need to produce our own guidelines and distribute them widely, and that means we need to start applying for foundation grants. We're involved in an ideologic war. Do we professionals work one by one with alienated, lonely, frightened, traumatized people, helping them to find greater security and creativity in their lives, or do we work to categorize them and then do something to them to make them less problematic to those around them, even if it costs them the development of their individuality? If our goal is to minimize symptoms, are we suppressing authenticity and thus increasing the person's sense of alienation? Now he's isolated from himself as well as from others. And what about our own authenticity? Are we there to enhance the profits of an industry? And what about the hyper-authority of evidence-based studies directing the standards of the professional community? If someone comes seeking psychodynamic treatment, do we place that person on a waiting list so that we can have a control group that we need for our randomized controlled treatment research to validate psychodynamic and psychoanalytic approaches? Physicians regularly medicate a person manifesting a psychotic thought disorder, or even if a clinician has a premonition of a possible emerging thought disorder. This trend is founded on at least two unproven premises. One, that psychosis is a brain disorder, and two, the longer the person stays in this dysfunctional state, the more brain damage is done and the less likely recovery will be. Neither of these premises has been scientifically validated after many attempts. While in earlier decades, a diagnosis of schizophrenia was only made after 6 months of continuing psychosis, now psychotic disorganization is often equated with schizophrenia, and the person and family members are told the patient will have to stay on meds the rest of their lives. John Bola, who worked closely with Lauren Mosier and his colleagues, have a recent publication, just again a couple of months ago, quote, the current international clinical practice guidelines recommending treatment of most cases of first episode psychosis with antipsychotics for 6 to 26 months is not supported by available evidence. It would seem incumbent on the scientific community to do the research needed to assess this clinical practice. Contrary to the widely cited conclusion of Richard Wyatt, in 1991, there is no evidence of harm from short medication-free periods of first episode psychosis conducted within carefully controlled research protocols. Thus, there's no ethical prohibition against carefully conducted, time-limited, medication-free research in first episode psychosis. Without evidence of the effectiveness of antipsychotics in early episodes and in the face of mounting evidence of harmful side effects, is it ethical to continue this widespread clinical practice, unquote. Francie and McGorry, the hypothesis that early stage illness would be more responsive to medication and that psychosis has a neuroprogression leading to pathophysiologic, symptomatic, and structural changes is now reconsidered. Immediate introduction of antipsychotic meds may not be necessary for all first episode cases, they say. Potentially safer interventions, such as comprehensive psychosocial intervention, may constitute effective treatment, at least for a subgroup of patients. To test that, at the Early Psychosis Prevention and Intervention Center, or EPIC, which Pat McGorry leads, a study has begun comparing intensive psychosocial intervention with meds with intensive psychosocial intervention with placebo. This is the very study that I had suggested to Pat McGorry at an ISPS conference some years ago, to which he gave me a two-word response: too dangerous. This was in the days when he and Tom McGlashan were committed to reducing the DUP, or duration of untreated psychosis, by medicating as soon as possible. So he was telling me that depriving a person of their meds for some study was just too dangerous for those people. It was felt to be unethical to deny patients antipsychotic meds. Now the stance has changed, even reversed, and now psychosocial approaches are called by McGorry more benign. They will also study neurobiologic changes. They'll be looking at gray matter loss and reduced hippocampal volume to determine whether these are due to the illness or secondary to the medication effects, as has been demonstrated in primates. So McGorry has done, let's see. Okay, I'll have to just read every other sentence. There's an organization based in Washington headed by Adriana Few-Berman, MD, called Farmed Out, that did a spectacular conference recently with very prominent speakers. Vera Care has been posting pieces on this issue, one by Lewis Kaplan of Harvard, in which he said that Haldol and antipsychotics and central nervous system depressants have been shown to delay and impede recovery. Piaget in 1932 emphasized the logic of autism and the logic of intelligence. What I got to in that paragraph that I'll skip is that we all want to be part of the group that for a professional to be able to read Whitaker or Waters or Grace Jackson is deeply disturbing, because it puts you at risk of being ostracized by your professional group or family. You become a crazy outsider, and what right do you have to be working with patients? So I think the profession, by and large, people have avoided those books because it's easier to watch TV. And the other thing is this issue of it's unethical to report a case presentation, that you're violating the patient's right to privacy, no matter how well you disguise it, and no matter how enthusiastic the patient is about the paper that you've produced. I think this has been another tactic of industry to get us to shut up. So then I was going to present a patient that I saw in consultation who was trying to convince me that she had a particular diagnosis. This was somebody that was looking for somebody to do meds management, which I don't do. So in any case, it was to encourage her to think about her family and not to think about her illness as having begun when she first became bulimic, but to look at what was going on in her life before. When I was in my mid-teens, my father was serving as an associate commissioner of health in New York State, and among his duties was accident prevention. He received a phone call one Saturday morning that a huge tanker loaded with chlorine gas was drifting towards the docks in New York City, in the New York City harbor. And the question was, should an alert be issued launching the evacuation of New York City? My father asked how much time he had to consider this and was told at most a half hour. He began pacing up and down the short hallway in our apartment. My mother ordered my brother and me to stay in our rooms. My father said later that he kept seeing scenes of the panic scenes from War of the Worlds and King Kong. He called back advising against an alert. No reporter was to be notified. The ensuing panic would result in more deaths than the possible release of chlorine gas. Meanwhile, the tugboat crews continued their work of pushing against the hull of the powerless behemoth. A few hours later, he got a call that all was well in New York Harbor, that boat was docked. Here was effective old-fashioned teamwork dealing with the crisis as it had done many times before. We need now to be getting together to help the floundering mental health system into safe port rather than merely watching as another new diagnosis leads to an explosion of harmful prescriptions. So with that, I'll stop. Thank you. Thank you.